Welcome back to Sino Medical Association. Today, we're diving deep into a critical care scenario that every medical professional needs to master. Let's break down a complex case of shock, step by step. Imagine this. A 68-year-old man is rushed to the emergency department. He was found unresponsive in his apartment. His medical history includes hypertension, type 2 diabetes, and he's been battling an upper respiratory infection for the past week. On arrival, his vital signs are alarming. His temperature is high at 38.9 degrees Celsius, or 102 Fahrenheit. His blood pressure is dangerously low at 78/42. His heart is racing at 124 beats per minute, and he's breathing rapidly at 28 breaths per minute. This patient is critically ill. During the physical exam, we notice something interesting. His arms and legs are warm and flushed, and his capillary refill is brisk, less than 2 seconds. When we listen to his lungs, we hear crackles at the base of his right lung. This points towards an infection, likely pneumonia. So, we have a patient who is hypotensive, tachycardic, tachypneic, and febrile, with signs of a lung infection. The immediate diagnosis is clear. This is shock. But what type of shock? The first-line treatment for most types of shock is aggressive fluid resuscitation. We give him 3 liters of normal saline intravenously. We're trying to increase his blood volume to raise his blood pressure. However, despite this large volume of fluid, his mean arterial pressure, or MAP, remains stubbornly low at 55 millimeters of mercury. A normal MAP is typically between 70 and 100. A MAP below 65 is concerning because it means the body's vital organs might not be getting enough blood flow. Since he's not responding to fluids, we need more information. This is when we decide to place a pulmonary artery catheter, also known as a Swangen's catheter. This is an invasive tool, but it gives us crucial hemodynamic data directly from the heart and pulmonary artery. The initial readings from the catheter are key. His pulmonary capillary wedge pressure, or PCWP, is 8 millimeters of mercury. The PCWP is an indirect measure of the pressure in the left atrium, which tells us about the heart's preload, or how much it's filled with blood before it contracts. A normal PCWP is between 6 and 12. So, his value of 8 is on the lower end of normal. This tells us his heart isn't overloaded with fluid. This is an important clue. If this were cardiogenic shock, where the heart pump is failing, we'd expect a much higher PCWP, often above 18, as blood backs up into the lungs. Next, we look at his cardiac index. It's 4.5 liters per minute per square meter. The cardiac index is the cardiac output adjusted for the patient's body size. A normal cardiac index is between 2.5 and 4. This patient's value of 4.5 is actually high. His heart is pumping a large volume of blood. This is another major clue. In cardiogenic or hypovolemic shock, the cardiac index would be low. So, let's piece this together. We have low blood pressure, a high heart rate, a high cardiac index, and a low to normal PCWP. The physical exam showed warm, flushed extremities. This constellation of findings points directly to a specific diagnosis: septic shock. Septic shock is a type of distributive shock. The core problem isn't a lack of fluid in the body or a failing heart pump. The problem is in the pipes, the blood vessels themselves. In sepsis, the body's overwhelming response to an infection leads to the release of massive amounts of inflammatory mediators, like nitric oxide. These mediators cause widespread systemic vasodilation. Imagine all the blood vessels in the body relaxing and widening at once. This dramatically increases the size of the container that the blood has to fill. Even with a normal amount of blood, the pressure inside this massively expanded container plummets. This is why his blood pressure is so low, despite a high cardiac output. The heart is working overtime, pumping furiously, but it can't generate enough pressure to fill the dilated vascular system. This massive vasodilation leads to a severe decrease in systemic vascular resistance, or SVR. SVR is the resistance the heart has to pump against to circulate blood. In septic shock, SVR is profoundly low. This is the hallmark of distributive shock. The heart is trying to compensate for this low resistance by pumping faster and harder, which explains the high heart rate and high cardiac index. This is what we call a hyperdynamic state. The warm shock with flushed extremities is a classic sign of this state, caused by blood rushing through the dilated vessels near the skin. Now, let's think about oxygen. What happens to oxygen delivery and consumption in this state? We can measure the oxygen saturation of the blood returning to the right side of the heart. This is called the mixed venous oxygen saturation, or SVO2. Normally, as blood passes through the body's tissues, oxygen is extracted from metabolism. So the venous blood returning to the heart has a lower oxygen saturation, typically around 60 to 80%. But in septic shock, something strange happens. Because of the widespread vasodilation and the incredibly high speed of blood flow, the blood rushes past the capillary beds too quickly. The tissues don't have enough time to extract the oxygen they need. This phenomenon is sometimes called luxury perfusion. The blood is flowing, but it's not effectively delivering oxygen to the cells. As a result, the blood returning to the heart is still highly oxygenated. This means the SVO2 in a patient with septic shock is often paradoxically increased, sometimes above 80%. This directly impacts another measurement, the artery-venous oxygen difference, or the AVO2 gradient. This is the difference between the oxygen content in arterial blood and the oxygen content in venous blood. Normally, there's a significant drop as tissues extract oxygen. But in septic shock, since the arterial oxygen is normal and the venous oxygen is high, the difference between them becomes very small. The AVO2 gradient is decreased. So, to summarize, the physiological state of our patient in septic shock. First, his systemic vascular resistance is very low. This is the primary problem, massive vasodilation. Second, his cardiac index is high. The heart is in a hyperdynamic state, trying to compensate for the low SVR. Third, his pulmonary capillary wedge pressure is low or normal. This rules out a primary cardiac problem and shows he is not fluid overloaded. Fourth, his mixed venous oxygen saturation, SVO2, is increased. This reflects the shunting of blood and the inability of tissues to extract oxygen effectively. And fifth, his artery-venous oxygen gradient is decreased, which is a direct consequence of the high SVO2. Understanding these hemodynamic parameters is absolutely critical for correctly diagnosing the type of shock and guiding treatment. In this case, since the patient is not responding to fluids, the next step would be to start a vasopressor, like norepinephrine. Vasopressors work by constricting the blood vessels, which increases the systemic vascular resistance, raises blood pressure, and helps restore organ perfusion. Simultaneously, we would be working to identify and treat the underlying source of infection with broad-spectrum antibiotics. This case is a perfect example of why a deep understanding of physiology is essential in critical care medicine. It's not just about memorizing facts. It's about connecting the dots from the patient's presentation to the underlying pathophysiology to make life-saving decisions. Thank you for joining us for this deep dive into septic shock. We hope this breakdown helps you in your clinical practice or your studies. If you found this video helpful, please give it a thumbs up. And don't forget to subscribe to the Sino Medical Association for more educational content. We'll see you in the next video.